afternoon, everyone. I'm Dr. Pratibha Thilak from Chaitanya Eye Hospital, Tiruvalla. I welcome you all to the Bear It All Anti-VEGF course, where we aim to deal with all the practical aspects of anti-VEGF therapy. Without much delay, I'd like to invite the first speaker, Dr. Praveen Murali, vitreoretina surgeon at the Eye Foundation, Kochi, to give his talk on pre-operative assessment.
So the common complication of intravenous injections are side discomfort, subconjunctival hemorrhage, vitreous reflux, and transient elevation of IOP. However, the most dreaded complication of an intravitreal injection, though rare, is endophthalmitis. And much of our pre-op protocol are designed to minimize or eliminate, especially endophthalmitis due to human error. As we all know, the range of endophthalmitis post-injection is around 0.019 to 0.09 per injection. The close examination of a large historical outbreaks of this endophthalmitis suggests that they are mainly due to non-compliance with the standard protocol, poor aseptic techniques, and pharmacologic compounding procedures. Eyelid and ocular microfloral surface. So this, the organism of these surfaces has been implicated as a source of infection in most cases of endophthalmitis. Because the bacteria can be cultured from the ocular surface of almost any person, certain risk factors make this patient more prone or more susceptible to the infection. By bacterial blepharitis, conjunctivitis, infection of the lacrimal drainage system, etc. These conditions may lead to abnormal elevated population of the ocular surface microbes or colonization of the ocular surface by atypical organisms which have greater virulence than the normal microflora. Along with this, host factors like poor immunity of the patient, like patient is on some immunosuppressive therapies, or if patient is on some diabetes mellitus medications and all. So when the patient comes to you, what we should see through the slit lamp are have a good slit lamp examination, look for any infection of the lids. It's always better to postpone this patient by a week or 2 weeks, treat this patient appropriately, then proceed with the injections. Now, where do we perform this injection? So in developed country, it's mostly performed in office setting. However, in our setting, we prefer an operating room, which is a more controlled and a sterile environment. If not OT, you can designate a clean room, and the clean room should be a sterile area. If it's in a multi-speciality setting, try avoiding this procedure where any other unsterile procedure is done, like drainage of abscess or cleaning of infected wound. The rooms should be cleaned before use to the same standard as operating room. When you come to intra-op, the lid retraction, the main goal of this lid retraction is to avoid needle contamination by the lashes, either due to involuntary or reflex lid closure, especially during the injection. The advantage of lid retraction is the sterility, easy of use, exposure, and patient comfort. This slide I like to insist on a very important way. If you go a decade back also, in the developed country, most of the retina specialists use povidone iodine. The advantage is it's cheap, it has broad spectrum over a concentration of ranges, a fast kill time, 15 to 120 seconds, no reported resistance, and very few reported cases of anaphylaxis. The concentration what we use is 5% povidone iodine for 30 seconds. But ideally you can use for 3 minutes, which significantly reduce the bacterial colonies formed. If patient has allergy, which is very, very rare, you can go for chlorhexidine. However, when you use chlorhexidine, don't use alcoholic chlorhexidine, which is toxic to the corneal epithelium. The eyelid you can use with 10% povidone iodine. Now, whether to wear mask or not, don't wear mask. If you see the infection rates, the endophthalmitis rate post-injection, the staphylococcus was seen around 65. However, streptococci was quite high. The streptococci in post-cataract are very, very less. It's in single digit. However, In post-injection, it's quite high as 31%. This is due to, it is believed to come from the oral cavity, either of healthcare provider or the patient. So due to just sheer volume, it's ideally good to wear mask. Along with one most important step is to have silence. All patients' information, anything what has to be told should be told outside the OT. Inside the OT, it is better to keep quiet or minimum talk with the patient. Topical antibiotics pre and post is controversial. The antibiotic doesn't seem to reduce the rate of endophthalmitis, and since we give monthly injection with long duration with multiple injection, the chances of resistance is always there. The good news is that povidone iodine is still the best with very few resistant cases. So coming back, few takeaway points. Verify the correct patient, correct eye, correct medication. All personnel in the room should wear a mask. The patient should not be asked to speak during the procedure. Topical povidone iodine 5%, a minimum contact time of 3 minutes. Skin and lid with povidone iodine 10%, and sterile drape to be used. The single most important thing we should always remember that this is like an intraocular surgery and should be treated equally seriously. The most devastating complication is end-off, and you must take every possible precaution to prevent infection. Thank you.
Thank you, Dr. Praveen, for the comprehensive talk. We'll take the questions at the end of the session. I'll invite Dr. Divya Alex, Consultant Vitreoretina Services at Ahalya Group of Hospitals, for her video presentation on technique of intravitreal injection.
Good afternoon, everyone. I'll deal with the technique of anti-VEGF injection. So we will see a video showing the technique of anti-VEGF injection.
Intravitreal anti-VEGF injection, pre-injection it is suggested
Iodine 5% eye drops 1 hour prior to the procedure is as good as a broad spectrum antibiotic 3 days prior. Intravitreal injection preparations. Under all sterile and aseptic precautions, prepare a sterile trolley containing eyelid speculum, plate type, calipers, cotton-tipped applicators, cotton swabs, eye pads, povidone iodine 10% solution. Povidone iodine 5% eye drops are kept ready. The patient lies down on the operation theatre table with good neck support. Proper painting of the area is done with 10% povidone iodine eye drop is instilled in the cul-de-sac. Remove anti-VEGF from the refrigerator just prior to the injection. It should never be frozen, exposed to direct sunlight, reused between patients, or used beyond expiry date. The kit contains a single-use anti-VEGF vial, 1 ml disposable, identified by purple hub, and a 30-gauge half-inch injection needle identified by yellow hub. Remove the cap from the vial and disinfect with 70% isopropyl alcohol and allow it to dry. Attach the blunt filter needle to the syringe. Then push the needle in the center of the vial stopper by holding the vial upright. The vial. Leave the filter needle in the vial and disconnect the syringe from the needle. Attach the 30-gauge injection needle to the syringe. Carefully expel the air from the syringe and adjust the dose to 0.05 ml mark. Do not void the injection needle. Intravitreal. Attach the blunt needle in the vial and disconnect the syringe from the needle. Attach the 30-gauge injection needle to the syringe. Carefully expel the air from the syringe and adjust the dose to 0.05 ml mark. Do not void the injection needle nor pull back the plunger. Carefully remove the cap from the needle without disconnecting it from the syringe. The syringe is now ready for the injection. Injection procedure. Ensure that the pupil is dilated for the procedure. Use sterile proparacaine 0.5% eye drops as topical anesthetist agent. The injection is preferably given under operating microscope. Apply the speculum. The patient is asked to look in the opposite direction from the site of injection. The most preferred site is inferotemporal quadrant, and so the patient looks towards supranasal direction. Prevent contact of eyelashes and eyelid margins with the injection site and needle. The site of the injection is at pars plana and is 4 mm posterior to the limbus in phakic eye and 3.5 mm posterior to the limbus in the pseudophakic and aphakic eye. Mark the injection site with the calipers. Move the overlying conjunctiva away from the injection site and also fix the globe with the help of a cotton-tipped applicator, which may be soaked with proparacaine 0.5% eye drops. Insert the needle with the bevel facing upwards towards the midvitreous, that is, the center of the globe. Insert the needle up to 1/2 to 2/3 of its length. The tip of the needle should be visible through the dilated pupil. Slowly injection site is pressed with the cotton-tipped applicator. Ensure that in solution. Check for vision, intraocular pressure and central retinal artery perfusion. Patch the eye for 1 to 2 hours. There is no need for prolonged patching. Avoid horizontal meridians at the injection site. While injecting, steady your hand by resting it on the patient's forehead or cheek. Can do eye massaging or AC paracentesis if required.
I'll just emphasize the points to ophthalmic microscopy as well as read the OCT, ensure the procedure to be done and mark the eye. It is always better to tag the hand also, like if you are injecting the right eye, tag the right hand, and you in the left, tag the left hand, and in the tag you can write the name as well as the brand of the injection. So emphasizing the use of 5% povidone iodine as Dr. Praveen has already explained, and usage of mask is a must both by the patient as well as the surgeon. Avoid talking while giving the injection as gram-positive cocci are the commonest infection following intravitreal injection and droplet infection may be the source. So in some anti-VEGF injection, it may come as the whole pack, but in some anti-VEGF injection, there may be only 18 gauge needle, so be prepared with the rest. So very important point is that when we remove the cap from the needle, the injection should be ready for, that is injection should be ready like to be injected at the site. So the problem occurs especially in the learning phase in the beginners. When you go to the injection site, the marking will be lost. So what you can do is, this is the Castrovecchio calipers. You can dip it in the povidone iodine and can mark in the area as 2 or 3 markings can be given, so that even when you displace the conjunctiva, the marking can be clearly seen. And always ensure that the tip and while withdrawing, to prevent the reflex, a cotton tip applicated dip in the povidone iodine should be applied to the withdrawn area. So post-operative care, the post-operative antibiotics, it's an area of debate, but it is the injector's choice whether to give or not. All patients should be given a discharge card mentioning the injection details, post-operative instructions, symptoms of infection, and a 24-hour emergency contact information. The patient is instructed not to rub or wash his eyes or have a head bath for at least 24 hours and avoid swimming for at least for 3 days. And the patient is informed that there can be floaters of bubbles for 24 to 48 hours, and this may be alarming as the patient removes the iPad from the home. There can be subconjunctival hemorrhage which can be alarming to the patient, so a word from our mouth will be consoling, and this make them understand that this will clearly go off within a 2 to 3 weeks time on its own. So the first postoperative visit, it should be within 3 days after injection. If the patient is unable to come for any reason, they can be asked to report to the nearest ophthalmologist if there is any unusual pain, redness or drop in vision at any point of time. And anterior segment examination should be looked for basically cells in the anterior chamber and the anterior vitreous, and the fundus also should be examined for any exudates, floaters or new onset peripheral retinal hemorrhages or vasculitis. Injection in both the eyes, it should be done at an interval of 3 days to avoid an increased level of circulating drug in the system. Thank you.
Thank you, Dr. Divya, for the very practically useful tips. Next, I would like to invite Professor Gopal S. Pillai, Head of Department Experience with Brolucizumab.
As we know, we have all completely moved towards intravitreal injections only now that photodynamic therapy is not available. So PCV is one condition in which now we have to treat with injections, and we do not have PCV. We have one particular thing in our hands, that is focal laser to the polyps. But other than that, we do not have PCV and we have to treat them with injections. And the ongoing challenge always, as always in neovascular AMD as well as PCV, is to treat of injections. So it's like if you give 12 injections in a year, it's really good for the visual acuity, but for the patient as well as for the surgeon, it gets really tight if you're giving that many injections. So how to reduce the number of injections and at the same time maintain treatment efficacy? So we should go into the newer pharmacology. It's like, what is a single chain antibody fragment? So that's a autonomous binding agent that no longer dependent on heavy molecular, FC chains or FL chains. That is not required. And so they are very, very small molecules which can penetrate easily, and their molar concentrations are quite high. So that is a single chain antibody fragment as opposed to a complete antibody which we have been using so far. So that's the drug in a single injection, because the molecule is so small. More potent inhibition of VEGF-A. Patients in which there is a type 1 choroidal neovascular membrane or a large pigment epithelial detachment, it can go deep into the choroid. A comparison between the available molecules right now, aflibercept, ranibizumab, bevacizumab and brolucizumab, you can see that the molecular weight is only 26. Number of molecules per injection, or the molar concentration, is almost 25 times that of bevacizumab. Good. A single thing which is there, and it penetrated the retina more rapidly in preclinical studies. So having said all that, now let us come to some real world scenarios. Now this is I have about 6 or 7 cases. So this is about presented in May with CNVM with subretinal hemorrhage. There were 6 injections of bevacizumab which was received and referred, and the patient's vision was 6/60, and this is the subretinal hemorrhage on presentation. You can see You can see the leakage of that polyp there. And previously received 6 intravitreal bevacizumab injection, but then had lost a follow-up and then had a subretinal hemorrhage, came back with the hemorrhage, and after 1 dose of brolucizumab, and we did a focal laser to that peripheral, near the arcade, we did a focal laser to that polyp, and then you can see that even though the central macula remains almost the same, the vision improved to 6/36. Now let's go to case number 2. There was a suspected exudative retinal epithelial detachment. You can see the large pigment epithelial detachment on the fluorescent angiography, and just nasal to the large pigment epithelial detachment. This is the autofluorescence, which shows the large pigment epithelial detachment here and some damage right in the center of the macula. And these are the OCTs in the, from February, March, and then in August. You can see that after a couple of injections, the pigment epithelial detachment is very large. It just fell down and fell down flat. Something which we had not seen in the bevacizumab era or even the ranibizumab era. We had not seen that. With aflibercept, we had seen such a thing, but this drop in pigment epithelial detachment is more consistent here. And this is by November. Patient's vision has improved to almost 6/6 parts. Now, case number 3. Here is a submacular bleed, which is like a fresh bleed as well as an old bleed, and there is a polyp on ICG and late leakage on indeterminate source on fluorescent angiogram. You can see the polyps here, and you can see that follow-up on ranibizumab, October 2021, February 2022, June 2022. No significant reduction in the hemorrhage or in the improvement in vision. And then we gave a brolucizumab there, and you can see the flattening of the pigment. This is a large pigment epithelial detachment, which completely almost flattened, and vision improved to 6/9 with focal laser as well. This is again a 63-year-old eye with CNVM with a submacular bleed with intravitreal implantation of brolucizumab in April. You can see the polyps right here, just on top of the, just here. And you can see the pre-injection 6/12 and 6/9 vision it improved to. And finally, we had planned a focal laser, which needed not to be done because there is no fluid over the last so many months. So this is again another case in which there is a lot of large pigment epithelial detachment and a subretinal bleed. You can see the post-injection visual acuity is 6/12 here, and then it improved to 6/6. So this is case 6, very huge, tall peak. Using brolucizumab in switch patients from ranibizumab or from bevacizumab or something like that, and almost all of them improved. Long-term stability, maximum efficacy, and duration. Duration is a very, very important key thing, because many of these patients with brolucizumab, after 1 dose, you do not require a second injection for maybe some time. So one patient had inflammation after the second injection, managed with topical steroids. So the Indian data so far is about 18,000 injections and about 100 cases of intravitreal inflammation, which puts it at 0.005. So this is to summary. So brolucizumab in clinical trials is non-inferior to aflibercept. Long-term maintenance and control on retinal thickness fluctuations can be there, and a lot of patients are on 3 monthly dosages. Welcome all of you to Kochi, 11th to 14th May for the Mega AIOC 2023. Thank you very much.
Thank you, sir, for sharing those interesting and impressive cases. Next, I would like to invite Dr. Shane Matthew.
Very good afternoon to all. What anti-VEGF agent do I inject? It's a long talk, but I'm trying to finish it within 10 minutes because I need to tell you a lot of things. So this is the story. In 2020. So what has changed from 2004 to 2022? Newer agents with longer duration has come in. There's reduced costs of innovator molecules. Biosimilars are patient supportive offers from pharma companies, thereby the cost of innovator molecules are coming down. Now we have a lesser concern for systemic side effects, and intravitreal injections are becoming CAT trial 5-year results saying that 80% of the AMD patients had active disease by end of 5 years. That means we are looking at diseases where we need to inject patients for decades together. Be it aflibercept or be it ranibizumab or be it bevacizumab, most of their efficacy is almost the same. Theoretically, aflibercept scores over ranibizumab, which scores over bevacizumab, but by and large, if you look at the graph, you know that most of the agents are the same. So, and keep injecting, and that gives the best result. The 5-year extension study also told us that the strict regimen, if you give it monthly, that is the best, but it's not always possible. Real world injection strategies, that is commonly what we do in our clinics, is not that stringent, but the study said that even if it doesn't give you the best result, but it has definite visual benefit. So it is okay not to treat as stringent as in a study group. With less So understanding the agents is very important. Dr. Gopal nicely described the newer kid in the block, brolucizumab. Aflibercept, ranibizumab, we know the cost of aflibercept was more, but now they've reduced it. So I prefer aflibercept because it has got better drying capacities, and systemic adverse effects is more or less the same between the groups. And biosimilars are also coming in a big way. Coming to Osidex, the moment you think about a dexamethasone implant, you talk about cataract and glaucoma. I know cataract is reversible, but if you look into the details of glaucoma, 6 to 8% of the patient had glaucoma, but the good news is most of them were controllable with topical medications. So we have 3 treatment regimens for anti-VEGF at least. We have a fixed dose regimen, which is the best, but practically difficult. When we have a treat and extend where you treat with initial 3 monthly doses of anti-VEGF followed by slowly extend the interval of injection by every 2 weeks. But mind you, by every 3 months to 4 months, we keep injecting whether the disease is active or not. But in PRN regimen, you keep injecting only when the disease is active. That means you are staying behind the disease. For example, in treat and extend, you stay ahead of the disease. For me, DME and RVO, the first line is always anti-VEGF agents unless there is inflammatory biomarkers or the patient is undergoing vitrectomy or a cataract surgery along with an anti-VEGF and has a very recent thromboembolic event. I might think of a dexamethasone implant or even triamcinolone. Nowadays, I use less and less of triamcinolone because the propensity of glaucoma is more with that. And I always do a loading dose followed by treat and extend for fresh cases. In CNV, loading dose with treat and extend is my way of regimen, but if there is large PED, if there are mature vessels seen sub-RPE, if the CNVM complex consists of mature vessels, and if the patient needs increased time interval between injections, I would think of aflibercept. If it's not working well, recently I've even started using bi-monthly aflibercept to see whether it is working. Brolucizumab is also a given option at this point. A word about switching of agents or switching from one anti-VEGF to the other. So if there is no response, there is no doubt we need to shift to another agent. But if there is some response, what do we do? In CNVMs, I would definitely switch to another agent after 3 doses if there is only some response. But in DME, I would like to wait for a couple of injections more because we have seen in DME that there are late responders who will respond in the injections later on. So there are situations where in good response cases, we still shift the agents. One is the patient's inability to come to frequent follow-up. We would want to use a longer agent which lasts for longer so that the patient come at a later date. Ocular side effects of medicines, of course, we need to go to a different agent. Always switch to an agent with a different mode of action and switch to a longer acting agent. But the most interesting part of the talk is, it is not always rosy. It is not always what is seen in trials that matters. In real world, when you sit in your clinic, what are the problems you face and how you decide? I would like to present 4 cases before you. The first case, this case is a case of choroidal neovascular membrane with an occult or a sub-RP CNV. So this patient, I explained all the anti-VEGFs available. Of course, the patient selected to use, you have a pointer please? Okay, sorry. So it might take little more time. So I talk about anti-VEGF to this patient, but the patient is willing to take only a biosimilar because of financial reasons. So what I do is I keep giving 3 injections. The retina is flat and nice. So then I have to make a decision. Should I go with treat and extend regimen or should I take PRN regimen? I know the disease is responding well. I know treat and extend is the best treatment of choice for him. But I select a PRN regimen. But again, why? Because of his try again. The patient comes back after 1.5 months, I see little fluid. That means there is reactivation of the disease. But it is definitely less than the primary fluid. So at this stage, I consider this patient as a good responder. Means the patient responded well to the initial agent. And this is a recurrence. So I would definitely continue this biosimilar in him. I wouldn't change any agent. And sure and certain, he is doing well, but I'm repeating injections every monthly. So this is case number 2, where you have a CNVM of the left eye. Right eye, I gave almost 30 injections from 2016, and it is stabilized at 636 vision. Now, me and the patient knows, yes, left eye is going to get at some time, and we caught it very early. 2018, 6.6 vision with metamorphopsia. So again, I discussed the entire anti-VEGF agents to the patient, and she decides to take a ranibizumab because she took that in the other eye. But what happens here is, the fluid is increasing. I mean, giving 3 doses of ranibizumab, but the fluid is actually increasing. This is a non-responder. This is what you call a non-responder. This is the time where we'll have to sit back and think whether to change agent. Before you change an agent, always think of any confounding factors. Is there anything else happening by which the patient is not responding? Is there any coexisting disease? Is there any missing of doses which the patient due to the CNVM, you shift the agent. So I chose aflibercept. You know, it has got a longer duration of action and it has got a better drying effect. I did not choose brolucizumab because there is I preferred aflibercept. So for 2 years, from 2019 to 2020, 2 years I'm managing this patient with aflibercept. Initially, I gave a loading dose of monthly aflibercept followed by aflibercept every 2 months. So I'm keeping the patient, so they come once in 2 months and I keep taking the injection. So I think there are a lot of events, so I'm cutting it short like a story. So in 2 years, what I see is I'm giving 2 monthly aflibercept, but sure and certain, by 1 year, I cannot sustain for 2 years. It is reducing to 2 months. It is reducing to 1 month. So slowly, tachyphylaxis is developing for aflibercept. To a point that I give injection, and 2 weeks later also, edema is not coming down. So in that point, I discuss the patient on brolucizumab, because it is time for me to take the chance of an intraocular inflammation, if at all. The chances are rare though. The moment I give intravitreal brolucizumab, it is flat again, patient is doing well. But sure and certain, now I don't get 3 months, I get only 2 months. And to a point that it has reached a point where now I give once in 2 months, but it is drying. So that means from a non-responding case, now it is a responding case with a good response, but with brolucizumab. So here the eye itself is prone for tachyphylaxis, what I feel. And this is the recent picture. This is the pre-injection picture with the cystoid macular edema. It is flat now. The retroimaging on the top side shows neovascular complex disease is going to recur after 2 months. Here I have a subfoveal thickness, and the topmost slide, the subfoveal thickness of 193 microns. But with 5 years of treatment, I could maintain the vision from 6.6 only to 6.12 N6. But if I was more aggressive in treatment, I would have saved the fovea a little more, but this is the best that patient could do. It has got hyperreflective foci here, multiple hyperreflective foci, neurosensory detachment, as well as a massive edema. My first choice would be to give Osidex. This is a real world situation. The patient doesn't want to take Osidex because he doesn't want to afford. He cannot afford. So again, going back to biosimilars. Razumab is taken once, twice, not much of change in edema. His vision acuity is not improving. Now he comes back to me and say that now we'll take Osidex. This is a real problem that you face in practice. So now I take Osidex. It is dry. Within 3 months, it's dry and nice. The patient takes off. He doesn't come for follow-up. After 3-4 months, he comes back again. The edema is propping up. I'm telling him that the edema is propping up, but he is not interested in taking injections. Why? The visual acuity is good. Now, as the visual acuity is dropping, suddenly the gentleman wants to take, but he wants to take only Razumab. It's a common man who cannot afford injections, but somehow managing to. Why I presented this is I'm giving Razumab, and the edema is not responding completely, but I can see a small neurosensory detachment here, but visual acuity is maintained at 6.9. He is happy. He is coming to me for repeated injections, but he has his own time. Now, can we compare this to expert treatment that we get in our studies? Yes, this is the real world experience, but it is important to continue treatment like this so that the patient continues treatment with you to get the best for him. I know I'm exceeding time. My choice of agent has come to a point where helping the patient to continue the treatment, be it choosing an agent with lesser cost or be it increasing the interval between injections, but not forgetting the safety of the patient. Thank you.
Thank you, sir, for the comprehensive talk on choice of agents. Next, I would like to invite Dr. George J. Manayat, Senior Vitreoretinal Surgeon, Arvind Eye Hospital, Coimbatore, for his talk on complications in intravitreal injection.
Good afternoon, everyone. So now you have heard from Shane about all good things. I am the bad man here. So let's look at all the complications regularly that we see with intravitreal slides. Let's do a case-based discussion. So our first patient is a 60-year-old man who has occult CNVM with good, but after 1 month, oops, the vision is 3/60 now, and we can see a very large RP rip under the macula, which is a very well-known complication of pigment epithelial detachment, CNVM. So in this situation, if the disease is active on so again a submacular hemorrhage associated with probably a PCV, polypoidal choroidal vasculopathy here, and anti-VEGF comes with a hand movements vision, and we have a massive breakthrough vitreous hemorrhage with a suprachoroidal hemorrhage as well. So breakthrough vitreous hemorrhage in a PCV can be a complication following anti-VEGF therapy, and patient underwent vitrectomy and silicone oil, and half by 60 vision was recovered. So the third case is a 67-year-old male, a defective vision 2 weeks and 618 vision. You can see this irregular PED subretinal fluid, some fibrin here, and thick choroid, and OCT and ICG FFA shows the ink blot leaks here, but here, patient was started on ranibizumab monthly injections. After 3 monthly injection, truly non-responder, so shifted to aflibercept. But still, here we have a paradoxical increase in fluid and PED. So sometimes after switching to a better anti-VEGF or a potent anti-VEGF, you can have this paradoxical response, and finally had to do with a combination treatment with PDT, photodynamic therapy, and in combination with aflibercept. So paradoxical response also worsening can also be seen with anti-VEGF injections in PCV CNVM context. So now let's look at diabetic retinopathy. Protocol S was a comparative trial looking anti-VEGF injections as a alternate. So, some of the case examples here. This patient, severe NPDR, early PDR, this flat NVE or flat fibrous problem was missed in the initial. After the injection, this is after we can have this angiofibrotic switch, or we call it a crunch phenomenon leading to tractional retinal detachment. This is again, prior to the vitrectomy, this very vascular surgery, Avastin was given intravitreally, but asked the patient to come after 4 days for surgery, but he comes after 2 weeks. See, all the vessels are occluded. We have a very fibrotic membrane, tractional retinal detachment, vision has dropped to hand movements vision. And after vitrectomy and timeline, after 2 weeks, what happens after in a PDR situation? You have to be very careful in giving anti-VEGF therapy for PDR, because this crunch effect takes 2 weeks to form the tractional retinal detachment, and it happens in around 5% of the patients with PDR. So it has to be kept in mind, because the anti-angiogenesis takes only 4 to 5 days, not more than that if you want to operate on a highly vascular PDR case. So if you are using anti-VEGF as an alternative to PRP in PDR, has to be very diligent follow-up, because 1/3 of the patients, if lost to follow-up, can come back to you with neovascular glaucoma or advanced PDR. So another patient with central retinal vein patient was underwent multiple intravitreal injections. As you can see, after 6th injection, it has settled down. But after 6 months, the macula is very dry and flat. There is an RP atrophy. So this is also a known complication, RP atrophy, following multiple anti-VEGF monthly injections. As you can see, you have a dry macula, but you have a macular atrophy. So in 7-Up study, after Anchor, Marina, and Horizon monthly injections, it was seen that using a fundus autofluorescence, almost 98% of the patients after 3 to 4 years of anti-VEGF therapy had some sort of atrophy at the macula. So this also has to be kept in mind when you're putting the patient on anti-VEGF therapy. So another aspect which already touched upon by the previous speakers is a non-resolution with anti-VEGF therapy, intravitreal injections. For example, this PDR patient post-PRP, there is a chronic DME of 2 years. After 3 Avastin monthly injections, shifted to Lucentis, shifted to aflibercept, it's still non-responder here. So in such situation, this patient had to be switched to Ozurdex injection, multiple Ozurdex also done a targeted PRP in a PDR setting. If you have a chronic DME, then better to target the CNP areas on wide field or ultra wide field fluorescein angiography to cover the CNP areas that are still skipped during the previous PRP. It might settle the macula. So macular edema. So the last case here, we have a young lady who has cardiomyopathy and history of blood dyscrasia, the picture was something like a BRVO in both the eyes with subtle submacular detachment here. So this patient, because of the history, we sent for a physician clearance, and patient came after 2 weeks. The submacular detachment has worsened, the vision has dropped to 5/60 and 2/60, but the blood report showed multiple myeloma, elevated protein fractions. This is not a vein occlusion, this is the venous stasis retinopathy in both the eyes because of the elevated proteins in the blood. So the systemic status, why more than a hypertension or systemic disease, has to be kept in mind while putting the patient on anti-VEGF therapy. The other systemic issues have to be kept in mind: a recent cardiac or a stroke history within 3 months, and even after injections, multiple anti-VEGF injections, you're starting for first 2 years, for example, the stroke or MI has to be kept in mind if the patient is prone to it because of systemic status. So the miscellaneous or other causes or other complications where it can go wrong is endophthalmitis, especially with Avastin or intravitreal triamcinolone, and you can have sterile vitritis, which has been earlier reported with biosimilars and now recently with Peginax also. And then we have glaucoma, especially with Dexemplant or IVTA, and the procedure related, what it can go wrong is a lens touch during the injection procedure. So thank you all for your kind attention.
Thank you, sir, for this very pertinent talk on complications. Next, I would like to invite Dr. Rahul R. Menon, Consultant Vitreoretina Services, Chaitanya Eye Hospital, Palarivattam, Kochi. The topic is, what are biosimilars?
Of the original drug. They are very similar to the FDA approved innovator drug, but not identical. Also, they are developed using cell lines that are unique to a given manufacturer and using different purification process. So they should not have any clinically meaningful difference in terms of safety and effectiveness with the original drug. Only minor differences in clinically inactive component are allowed and should have the same mechanism. Like the original biologic is not similar to, not very same as the relatively simple to duplicate and manufacture, whereas innovator biologic drugs are 100 to 1000 times larger than the generic molecules. And it's basically hundreds of amino acids are biochemically married in a particular sequence within a living system. So this is the difference between generic and biosimilars. So the time and cost required to make a biosimilar is significantly less than that of developing a new drug. So hence the cost of the biosimilars are sometimes half the cost of the original product. But the reason for the development of biosimilars is basically because bevacizumab has often been sidelined due to its off-label use and compounding issues. But if you look at it, the cost of a biosimilar in the market today, it is still costlier than a single aliquot of bevacizumab. So the finance required, if an average innovator biologic and it takes about 10 to 15 years to develop, whereas a biosimilar requires only 8 to 12 years, and the cost is about measly $100 to $200 million. So theoretically, this cost saving are then passed on to the patients. The data requirement for biosimilars also are different. For a reference original product, it requires 2 clinical trials for US FDA clearance, whereas the biosimilar only requires single comparative efficacy trial. But doesn't mean that the biosimilar have a lower approval standards. Now, a biosimilar has the advantage of being able to extrapolate and piggyback on the original innovative drug to get approval for all the original drug indications. Now, also in research, the innovative drug can be compared with any anti-VEGF agents or a placebo, whereas a biosimilar must only be compared to the original drug. Now, Razumab is the world's first biosimilar which was approved for several macular disorders. It got the clearance by the DCGI in Feb 2015. It's approved for the treatment of wet AMD, diabetic macular edema, CMA due to retinal vein occlusions, and myopic CNVM. There are a few concerns when we saw a few cases of sterile endophthalmitis a few years back. and which made the VRSA to actually issue an advisory to halt its use for a certain period of time. Also, there's a interchangeability substitution with the innovator molecule, and its reimbursement is a little problem because there's a paucity of legal regulations addressing the use of biosimilar in India. So why don't we have a biosimilar for all the drugs? Because the US, the Price Competition and Innovation Act of 2009 gives exclusive 2-year market and 4-year data exclusivity. So no biosimilar can be produced before this. Now this exclusivity is just, the main intention is to encourage biologic research and development. So Lucentis got the US FDA approval in 2006. Recently, the US FDA gave approval for the first biosimilar, Buvis, developed by Samsung Bioepis, for all the treatments of all the indications of Lucentis. Now, there are newer biosimilars that are being developed. Biosimilars being developed for bevacizumab. Now, it's little a thing to ponder because biosimilar to an off-label drug is little something we should be worried about. Also, since the patency period for aflibercept is ending in 2020, there are a lot of companies which are lined up and a lot of for the production of biosimilars for aflibercept. So these are the few biosimilars that are available in India: Razumab, Bizumab, Ranizurel, Osiva, and Raniase. Thank you. The only a couple of points I would like to ponder is regarding the patient counseling. Now, just like a placebo effect, I had a patient of mine, which I had, he was a case of called CNVM. I gave him the injection option of anti-VEGF as well as biosimilar. He had around 636, 624 vision. So because of financial issue, they preferred biosimilar. Took 2 injections, had a very excellent also was anatomically was very good. There was very few intraretinal fluids, but the patient was not happy because somewhere in his mind this point has creeped in because it was not the original drug. Finally, they had to loan money from somewhere and took the 3rd injection. That was they took it Accentrix, and finally the patient's vision was good, everything, but that that concept that gets into your mind is because it's not an original drug. Sometimes it creates a a nocebo effect in the patient. So I would definitely like Lalis's idea, like opinion about how does he tackle such counseling issues.
No answer, Rahul, is talk, talk and talk. See, you have to talk to the patient. That is the answer. Because it has to be convinced. I tell them that's made in India, and because patient goes by your confidence.
Yes, sir.
Patient does not if you tell them this is imported, this is Indian, so he'll go by imported. But if you say this works as good as this, so he'll agree to you.
That is the thing that is kept in the patient's mind. So
no, but today, believe me, you can't write any imported brand also. You have to write generic name as per law also. The Ministry of Health has given guidelines. If you write Accentrix or Lucentis, you can be caught. You have to write Ranibizumab. In fact, our center received a show cause notice that why have you written, Razumab or this Accentrix or Razumab? Because they supplied. Today you can't do that. But patient in this country, believe me, goes by your confidence. If you tell him it is my eye, I will take this, he will take. But if you say, nahi, ye imported hai, ye Indian hai, ye wo hai, to as a human psyche, you go for higher price. Yeah, don't say original molecule. This is not a copy.
It's not a copy too.
But I think we had some wonderful presentations, but time is not on our side, but lovely presentations by Dr. George and Dr. Shane, Praveen, Divya and Gopal. I don't know, time is, we can't have discussion now because Gopal will not allow this. But you see, tachyphylaxis we learned from his presentation and a couple of complications which he showed. But now believe me, 5 of your cases, there are lessons to be learned rather than complications. You see, today, if you show RPED with subhemorrhage, I will not start him on ranibizumab. I'll start straight on Pagenex. Because Pagenex, first time we have seen flattening of RPED occurring. Because nowhere, whether you use ranibizumab or even aflibercept, the response of flattening what Gopal, I think, showed in the first few slides is dramatic, not to be seen at all. But five cases of yours are lessons learned rather than complications. RIP can happen in any of the patient, but PCV, we learned some lesson. And protocol S, what you raised, PRP versus anti-VEGF, that crunch phenomena, that's again patient has to be warned. You see, we all of us have seen such patients, but PDR, you see, we never now recommend anti-VEGF alone. It has to be coupled with laser always. Otherwise, you see, you can't then blame the patient that you give an injection and he does not come for follow-up. Yeah. So in those patients, I will tell them this is only temporary. Laser is the permanent option. You have to have laser first. So a lot of good learnings. In fact, we want to discuss, but time is not on our side. So thank you so much, Dr. Pratibha, Dr. Rahul, and the organizing committee for such a wonderful session. But for the lack of time, we will not able to take up questions.